Welcome to Morning Commute, exploring advances in acute myeloid leukemia, frontline care of patients with FLT3 ITD. In this episode, managing FLT3 treatment-related adverse events in patients with AML, Dr. Harry Erba and Dr. Justin Watts look at this drug class, how they are used in AML, and managing any treatment-related adverse events. Morning Commute is developed by Projects and Knowledge powered by Kaplan and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Daiichi Sankyo. Information about the faculty and disclosures can be found at morningcommutepodcast.com/AML4. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Erba is a professor in the Department of Medicine, Division of Hematologic Malignancies and Cellular Therapy at Duke University in Durham, North Carolina. Dr. Watts is an associate professor of medicine in the Division of Hematology and is chief of the Leukemia section at the University of Miami in Florida. I am your host, Candace Hoffman. Dr. Erba will begin the discussion.
Welcome back, Justin. In our last podcast, we had a fairly in-depth discussion about FLT3 and FLT3 ITD, the importance of testing our AML patients, what it means for prognosis. The good news is not only are there treatments targeting FLT3 ITD, but there are three of them. Midostaurin, that's approved in combination with intensive therapy for patients getting 7 and 3, followed by high-dose cytarabine consolidation. For FLT3 ITD and FLT3 TKD mutated disease. Gilteritinib as a single agent approved in FLT3 mutated AML that's relapsed or refractory following prior therapies. And with the latest FDA approval, quizartinib, which has been approved for adults with FLT3 ITD mutated AML that's newly diagnosed in combination with 7 and 3 chemotherapy, consolidation, and up to 36 cycles of maintenance or continuation therapy. But I think there are a number of really important points to discuss and maybe to help allay some of the confusion around what's published and what's been approved. And let me start with the dosing of the FLT3 therapies. And I'm really going to focus in this part of the discussion on quizartinib as the new drug. We have a lot of experience dosing midostaurin, 50 milligrams twice daily, days 8 through 21, with intensive chemotherapy or consolidation. But how about with quizartinib? So I mentioned earlier that in the clinical trials that were done and in Quantum First, the dose of quizartinib was 40 milligrams once daily, days 8 through 21, following induction and following the high-dose Ara-C consolidation. And it was 60 milligrams per flat dose, single dose a day during continuation. What I didn't mention is actually you ramp up the dose during continuation from 30 to 60. However, when the FDA approved quizartinib under its trade name from the sponsor, they carefully pointed out that the amount of the actual quizartinib in those 40 and 60 milligram pills was less. And so they the sponsor decided to create two pills that would, when given together, or 2 doses, 2 pills a day, would come up to the dose of quizartinib that was in the clinical trial. So there's a 17.7 milligram tablet and a 26.5 milligram tablet. Basically, the way to remember this is that the sponsor made 2 strengths. One of the tablets, the 17.7 milligrams, is meant to be used during induction consolidation. And the other tablet, 26.5 milligrams, is meant to be used during the continuation phase. And the full dose in both of those settings is 2 tablets. Now, why have it divided into 2 tablets? Why not make a single tablet? Well, because in the clinical trial, doctors were allowed to use other drugs that could inhibit CYP3A4, and quizartinib is a substrate for CYP3A4. So, of course, here the concern would be toxicity when using a FLT3 inhibitor. Many of us believe in the use of the strong CYP3A4 inhibitor posaconazole, an antifungal antibiotic during induction and maybe consolidation therapy. And so if you were to use a strong CYP3A4 inhibitor, you would use half the dose of quizartinib, which would be one tablet, 17.7 milligrams during induction consolidation, and then 26.5 milligrams during the continuation phase. So that explains the dosing. But now let's turn our attention to the toxicity profile. And Justin, do you want to start us off on that discussion?
Sure, happy to. So in terms of the general toxicity profile of FLT3 inhibitors, it really differs between first and second generation FLT3 inhibitors. Midostaurin, being a first generation, is not as myelosuppressive in general. When given in combination with 7+3 chemotherapy, the setting in which it is approved, there wasn't a big difference in toxicity profiles, if really any, between the two arms, nor was there a difference in early mortality. Midostaurin, although this wasn't clearly seen in the induction consolidation phases, is associated with GI toxicity, and many of us who've used it do notice that during maintenance therapy, and this has also been shown on some other clinical trials, that with continuous therapy, there can be significant GI toxicity, sometimes perhaps even up to half the time, I believe, in some studies requiring it to be stopped. So that is a consideration with midostaurin. The intermittent dosing chemotherapy is generally pretty well tolerated, though, other than just the general side effects of the induction therapy, right, which we all know. The other ones, quizartinib and gilteritinib, I think what's more notable is myelosuppression. And this can be seen even as a single agent, but especially in combination therapies, either with chemotherapy in quizartinib's case, or with in clinical trials looking at it with venetoclax-based therapies in gilteritinib's case. And I think this is because these are type 2, they're just very potent FLT3 inhibitors. They obviously have key differences. Quizartinib is a type 2 inhibitor, so it can really just shut down FLT3 wild type as well. And it also hits KIT, I believe, which may lead to the myelosuppression. In its case, in gilteritinib hits multiple other kinases and is also known to be myelosuppressive, and is also a very potent FLT3 inhibitor, but a type 1 inhibitor. So the myelosuppression is real, especially when you're considering that older patients were treated on this study on Quantum First, between the ages of 60 to 75, as we discussed during the last podcast, and there you may be particularly concerned about the increased risk of toxicity. And in fact, there was a slight increase in early mortality on the quizartinib arm compared to the placebo arm on Quantum First, and this was probably mostly driven by the older patient population. Obviously, the overall survival benefit was still borne out, and it was significant, and there was about a 10% magnitude of survival benefit with quizartinib. We know that, but myelosuppression, primarily neutropenia, is something to be aware of, and also with gilteritinib and other combinations, which are now being done on clinical trials. In terms of other non-hematologic toxicities, kind of what comes to mind is probably the most noteworthy is the issue of QT prolongation with quizartinib, which is known, has been seen on monotherapy trials, and on the Quantum R study, there was actually more of a signal there, I believe. On the Quantum First study, there was a signal for QT prolongation. It was modest. It was not striking, but it was real, and it was notable, and it is worth mentioning, and it is on the label. And it's something that certainly has to be monitored for, and electrolytes depleted and so on. In terms of the rate, it was 13.6% on the quizartinib arm of QT prolongation. I believe that's grade 3 or higher, and only 4.1% on the placebo arm. And there were 2 cases of cardiac arrest on the quizartinib arm, and one of those in the setting of severe hyperkalemia, but regardless, that was seen. And 2 patients also discontinued due to QT prolongation. So it is something certainly to monitor. The last thing with serial EKGs, and there is a baseline and serial per the package insert, and there is clear guidelines for how to do that, including during maintenance. And the last thing that can happen with FLT3 inhibitors, particularly monotherapy, and the more potent ones, is the potential for differentiation syndrome, although that can be quite tricky to tease out differentiation versus progression. But there have been documented cases of differentiation syndrome with gilteritinib, and unlikely to see that most likely in a chemo combination study. I don't know, Harry, if you guys saw any actually on Quantum First. I'd be interested to know. So I guess with that, I'll hand it back to you.
Yeah, thanks, Justin. No, it's an interesting point about differentiation syndrome with the FLT3 inhibitors. It's clearly been seen and reported with gilteritinib and others, active drugs. So I haven't seen or heard of it with midostaurin, which generally doesn't lead to remissions on its own anyways. And in general, as you know, when we combine differentiating agents with intensive chemotherapy, we tend to decrease the risk of differentiation syndrome in, for example, acute promyelocytic leukemia. That was clear. Having said all that, we did not see differentiation syndrome with the use of quizartinib in the Quantum First study. Gilteritinib, yes, as a single agent, that has been reported. And so I think it's worthwhile recognizing that as a possible toxicity of FLT3 inhibitors in general, especially active ones, and being on the lookout for differentiation syndrome, even if you're using quizartinib. Again, generally, we haven't seen it during the induction. And of course, you're not going to see differentiation syndrome once the disease is in remission during consolidation or during maintenance. So I think that's less of a concern. Yet to add to the discussion about the myelosuppression, I in Quantum First, I do believe there was a longer duration of low counts, especially the neutropenia. That signal's also been reported from the PRECOG and the HOVON study. We don't have the full results of those studies of gilteritinib versus midostaurin, but the same concern about slower count recovery when you're adding in a potent FLT3 inhibitor that might be attacking and inhibiting other kinases besides FLT3. So we definitely have to take that into account. And it makes me think about the lower, or the higher, I should say, early mortality at 30 and 60 days that was reported in the Quantum First study in patients 60 and older. Now, I'd like to believe that some of that might be due to the fact that we don't treat many of these patients anymore with intensive chemotherapy. But at the time of the study, there really wasn't in many countries any other option other than a hypomethylating agent. Venetoclax had not yet been approved, as I mentioned. And having said that, as we discussed, HMA venetoclax is not a great option anyways, based on the clinical trial results that we've seen so far. But nevertheless, you have a patient in front of you, you need to treat them. And so there may have been patients on that study who were treated by their physician who today would not, on Quantum First, that might not be treated with intensive therapy. And I've got to believe that's true because no one really knows how to define fitness for intensive chemotherapy. And I think part of it has to do with, do you have another option? But I think the point here is what you made before. If you have an older patient, regardless of age, that you think is fit for curative therapy, then the Quantum First study supports the use of quizartinib there. However, we need to be cognizant of the myelosuppression that can be seen with second-generation FLT3 inhibitors like quizartinib, like gilteritinib, and manage these patients appropriately. I think it's going to be interesting to take a deep dive into the Quantum First data to see what was actually done for supportive care. The clinical trial did not mandate specific things, but how many sites used GCSF to get count recovery at the time of aplasia, how many sites used the azole antifungals, antibacterial prophylaxis. It's going to be important to get that data. And I think it'll also be important to see who these patients really were who were older. I mean, is the signal for earlier mortality in patients I'm just throwing this out there, I don't know yet, with a worse performance status, like performance status of 2 versus performance status 0 to 1. So again, we really need to look at that data so we can understand who really benefits from the addition of quizartinib to intensive chemotherapy. But I also think we have to expect the myelosuppression and use prophylactic antibiotics and growth factors. In terms of the QT prolongation, I agree with you. It was a modest difference. If the grade 3 QT prolongation was in 2.7% of patients, let's say 3% of patients, and with quizartinib and 0.7% with placebo. So clearly higher, but I'd like to point out that, remember, these were patients treated on a clinical trial where you had all these people overseeing what the doctor was doing, the clinical pharmacist, the investigational pharmacist, making sure the electrolytes were okay and making sure that they weren't on any other drugs that prolonged the QT, and doing appropriate dose reductions if the patient was on a CYP3A4 inhibitor. And so those are the kinds of things that I think we're going to need to really stress in our own practices as we bring this drug forward into our practice. The management of the myelosuppression, specifically neutropenia, and the management and prevention of QT prolongation. Because in terms of other toxicities, I personally haven't seen a great difference between quizartinib alone or with intensive chemotherapy. Intensive chemotherapy alone or intensive chemotherapy with quizartinib in terms of other toxicities other than the myelosuppression and the QT prolongation. The final thing I'd like to say about the QT prolongation is this drug has a REMS program associated with it, specifically for the QT. I could tell you the program that Justin and I both did. It's 10 slides to look at. You take a 10-question survey afterwards, which is pretty straightforward. And I would say the only thing that's in there, other than what we already know about how to manage QT prolongation, is the FDA wants the investigator or the clinicians to realize that this is one of the first drugs, it might be the first drug that they're approving, that is an inhibitor of what's called the slow rectifier channel in cardiac tissue. And so they're a little bit concerned about a little bit more concerned about toxicities that might be seen down the road that weren't seen with other drugs that inhibit these rectifier channels that govern QT prolongation in the heart. So the thing that makes it a little bit difficult for you and me to use is that not only do we have to do the REMS certification, but our pharmacists have to do the REMS certification. So but the good news is you only have to do it once. You don't have to do it for every month of prescription like some other REMS certifications where you have to get an authorization number each time. It's only once that you do it. So I think that really kind of covers this. The only dosing I didn't mention earlier, to come back to it, is the gilteritinib dosing, which is 120 milligrams once a day, 3 40 milligram tablets. That's the full dose. Again, dose reductions in the setting of CYP3A4 inhibitors down to 80. One of the reasons I remember that the sponsor chose 120 as their final dose or the recommended phase 2 dose is that we have pharmacodynamic data that shows that even at doses of 80 milligrams, you still turn off the FLT3 autophosphorylation using those plasma inhibitory assays that have been developed by Mark Levis. And so even if you have to dose reduce from 120 to 80 with gilteritinib, you're still giving the patient what may be an effective dose. So I think we've really covered, the data regarding these FLT3 as a target, its prognostic importance, the importance of testing. I think we've covered the types of inhibitors that have been developed, the 3 inhibitors that are currently available in the newly diagnosed patients in combination with intensive chemotherapy, and gilteritinib specifically as a single agent in relapsed refractory disease. But the one thing we haven't talked about, Justin, is how every day the leukemia always proves to be smarter than we are. And especially with targeted therapies, resistance is always seen. at some point. So can you give me your thoughts about the resistance mechanisms that are coming to light with the FLT3 inhibitors, and especially the type 1 versus type 2 and things like that?
Yeah, absolutely. I think that's a great thing to close on. Just to clarify the QT prolongation, I said 13 to 14%, but that was with quizartinib on the quizartinib arm, but that was any QT prolongation. I believe you said grade 3 was, or greater was 3%, or
It was lower. It's 2.7.
yeah, yeah, it's okay. That's good to know. It's good to know.
And we need to be vigilant and control those electrolytes. Watch the other drugs, CYP4 inhibitors, try to avoid them, and drugs that prolong the QT interval. So it is a signal of toxicity that we have to recognize.
For sure. Okay, in terms of resistance, this is an area of discovery still, of course, and it does differ to some degree between type 1 and type 2 inhibitors. Before we talk about that, I think it's worth mentioning just probably the most common pathway of resistance emergence with actually many of these new therapies. FLT3 inhibitors, IDH inhibitors, and even then HMA is the emergence of RAS pathway mutations. Either that were already there as a subclone small at the beginning, or maybe already detected, or that were selected for and emerge on treatment. And this is really, I think, very interesting. And we've seen so many of these patients who have gone on NHMA and then a FLT3 or an IDH or even all three at some point and end up with this monocytic RAS mutated AML. And this is so interesting to me because when you look at the ELN risk stratification, right, RAS is not on there.
Yeah.
Right. And that's because the ELN were developed from clinical trials done with intensive chemotherapy in Europe, right? VNH made nothing to do with the ELN. So, the best therapy for RAS mutated AML is actually cytarabine and chemotherapy, right? Which we have trouble giving to these older adults, as we've been discussing. So I think that's really important to know. And if there's any multi-kinase inhibitors that are going to also target RAS pathway at some point there, that's going to be, I think, very important for older adults in the future. Who have that kind of Achilles heel. Obviously, if there's a P53 mutation, especially if it's biallelic, that could be another mechanism of resistance, but we don't see FLT3s occur that commonly with P53, especially biallelic, unless maybe it's a late hit driving overt proliferation progression. And so other than that, I think it really is important to focus on the type 1 and type 2, because one of the initial concerns with quizartinib as a monotherapy was the emergence of TKD mutations, as you know, and because it doesn't hit those and you may be selecting for those, it may have some effects on some of the D835 TKD mutations, but really those prevent its binding, I believe, by changing the general properties of the enzyme and its conformation and not being able to access the hydrochloric pocket and so on for the quizartinib and other type 2 inhibitors. That TKD mutations are generally associated with relapse, particularly the gatekeeper mutation, I forget the number, which really completely blocks its binding and also confers some resistance even to gilteritinib, which is a which is a type 1 inhibitor. That being said, I think when you're giving quizartinib, such a potent FLT3 ITD inhibitor with chemotherapy and getting these deep MRD negative remissions, and the TKDs aren't usually there at diagnosis. They can be, but that's rare. Both of them being there. I don't know if you know this, if we really saw that much emergence, if any, of TKD mutations that relapse. And the other, gilteritinib, obviously there's not a concern with TKD because it hits both, unless it's the gatekeeper mutation. And that being said, one final point, I think, regardless of what FLT3 inhibitor you use, is you can relapse with the FLT3 mutation still there, and you just have some resistance to the inhibition, or it may be lost, in which case, again, there may be RAS or some other mutations driving the leukemia. The last thing I'll say is sometimes we'll see FLT3 mutations with an IDH1 or 2 mutation, especially an IDH1. And that's an interesting question, right, of what to do if it's a relapse refractory patient and you're considering a targeted therapy. My thoughts are the FLT3 is the primary driver there. I would probably go with FLT3 first, actually I would go with a FLT3 inhibitor first, especially if it's an ITD mutation, as in most of the IDH inhibitor, really all of the IDH inhibitor studies, whether it's everolimus, enasidenib, olutasidenib, FLT3 ITD patients really just don't respond, or very few, to IDH inhibition. There are clinical trials, I think, using both, but they don't occur that commonly together, but they certainly can. Any other thoughts there, Harry? I think it's a really interesting area, and hopefully one we can make progress in with combination therapies.
Yeah, no, I mean, when I think about the FLT3 inhibitors, this whole argument between type 1 and type 2, and, with a type 2 inhibitor used as a single agent, when we've seen resistance, often you're seeing a FLT3 TKD mutation show up. And that doesn't even mean that we know that that's driving the relapse, but it stands out because the drug is not active against FLT3 TKD. On the other hand, as you mentioned, the leukemia is always smarter. So if it's a FLT3, it's a type 1 inhibitor, RAS mutations tend to be what we see in those patients. So, and I agree with you about the point about targeting FLT3, but let's face it, FLT3 is a late event in leukemogenesis, right, driving proliferation. So it's hard for a differentiating agent to work if the disease is exploding in front of you. And so I think we have a lot to learn about, combining and sequencing these drugs. And I guess that leads me to, my final points here about, the future of FLT3 inhibition. I think it's clearly showed benefit in controlling the disease. These very potent second generation type 1 or type 2 inhibitors are very potent, control the disease, even as single agents can lead to remissions. But they have known toxicities of myelosuppression, and the remissions are not durable, and we shouldn't expect them to be durable since we're only targeting a late event. And so I still think we have, obviously we have a lot still to do in AML in general, but also in FLT3 mutated AML, and especially in older patients who can't tolerate intensive therapy. In terms of looking to the future, it would be nice if we can get drugs like quizartinib and gilteritinib and midostaurin approved on a timeline that's quicker than 10 years for a phase 3 study. And here's where prospective trials that use FDA-approved, CLIA-certified MRD assays that predict survival or response, but especially survival, are going to be key. And so one thing that I'm very proud of in the Quantum First study is that's one of the first studies that showed that an MRD assay did correlate with long-term survival. So the depth of remission on an MRD assay correlated with long-term survival, regardless of the therapy that the patient got. And of course, there were deeper remissions with the study drug. So I think looking to the future, I'm hoping that we can satisfy that need of developing these MRD assays that will allow us to develop therapies quicker for our patients with AML. Justin, what are you looking forward to?
No, I think that's a very important point about the MRD with the FLT3 ITD NGS assay down to 10 to the -4, less than that being considered negative, being associated with overall survival. I think that was clearly shown on Quanta First. I think that should, is at least one of the MRD assays that will emerge as really the standard of care, because it really does drive therapeutic decisions, gives you prognostic information, may impact your decision to do maintenance therapy post-transplant based on Morpho and Quantum First, which we've touched on previously. I think I'm also, back to the resistance one, one of the and FLT3 being a late event, even though sometimes the burden will be very high, it's often usually a late event, after the 3A, then the NPM1, then you get the FLT3, or in older adults, it may be more polyclonal, more and actually subclonal. But it typically occurs in a normal karyotype or near normal, maybe trisomy 8 leukemia, right? CH-driven leukemia, where it's a late accelerant. But it also occurs with fusion proteins, really all of them. And the impact there, as I think we alluded to, is also less clear. And one last thing I wanted to ask you about, and doesn't really matter in APL, for example, probably not as much in core binding factor leukemia, can be seen in high-risk fusions as well, inversion 3, 6, 9 translocations, and MLL. I'm also not sure how much it impacts the disease there, except it's making what's already bad a little bit worse. But it's hard to imagine that a FLT3 inhibitor as a single agent, of course, is going to work in inversion 3, for example, and even with chemotherapy. It's hard to imagine. But with the advent of menin inhibitors and the menin inhibitor trials, and I've been wondering this: what is the impact of the FLT3 in those patients? Is it subclonal? Does it matter if you hit the MLL and you block the differentiation? What's the FLT3 doing, and is there a role for combination therapies and so on?
Yeah, that's a really important question. All I can tell you so far is in both with revumenib and ziftomenib, the two menin inhibitors that are furthest along, there have been complete remissions seen even in patients who have FLT3 ITD mutations and other mutations that drive block and differentiation, like the IDH mutations. Now, the detail of that, we don't know. So the question you asked, was that just a subclone? Were these patients very proliferative? I don't know yet, but it does harken back to the point you raised about APL, and we said before, 25% of the patients with APL will have a FLT3 ITD mutation. Now, those patients almost always have proliferative disease. But what's interesting there is that we get very high cure rates with arsenic trioxide and all-trans-retinoic acid, even in high-risk disease, only by adding some myelosuppressive drug at the beginning. Idarubicin in some studies, gemtuzumab ozogamicin in others, different ways of doing that. It's almost like if you can just control that proliferative signal, then you give the opportunity for the differentiating therapy to work. So one of my thoughts about sequencing these drugs, and you brought this up, is if I have a patient like that who has truly FLT3 ITD driven disease, give them a FLT3 inhibitor, just like you said, knock it down, and then add in the differentiating agent. Because if you try to do it the other way around, the disease is just not going to be controlled. But I think we need well-designed clinical trials to see if that's right or wrong, though.
Very interesting. I mean, we're trying to emulate or replicate the arsenic story, and at least all fusion-driven leukemias, and any leukemia, you can think of Ivo-Aza as being somewhat not as good, but quite good in IDH1 mutated AML, and then the role of adding it in there, and then what is the combination partner for menin? Begs the question, but we will see.
Those studies are being designed, as you know, and launching now, and a few patients have been treated. So we have a lot to look forward to, and not only in patients with FLT3 mutated disease, but also in clinical development for patients with AML and other subtypes in different disease states, and especially for the majority of patients that we see, those older patients who cannot tolerate intensive therapies or allogeneic transplant. A lot of work yet to be done, but I've really enjoyed reviewing the progress we've made in FLT3 ITD mutated AML. Thanks for joining me, Justin. Really been a pleasure.
My pleasure. Thank you.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/AML4. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming service, or download our Morning Commute app. Thank you for joining us today.